You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Dr. Shreya Shah, healthcare informatics leader at Stanford Medicine. We discussed her path into clinical informatics and the role of AI in reducing clinician burnout. We also discussed the need to balance AI integration with clinical judgment, emphasizing that AI should serve as a support tool to enhance, rather than replace, clinical reasoning and decision-making. Let's plug in. Dr. Shreya Shah, welcome to the podcast. Where do we find you today?
Hi, Craig. Thanks so much for having me. I am in my home office in the Bay Area in California.
Awesome. And how's the weather? Is it always good in Northern California?
It's pretty good. Can't complain. Nice weather today. We've had some rain, which I think California needs. Starting to feel a lot more like spring now, which is great.
Awesome. Well, that is, it should just be spring all the time, but then you'd be living in San Diego. All right. Well, so you are at Stanford and you came to my attention, at least, as you put out a paper in JAMA, and I thought that was an interesting paper among other research that you've done. Before we get into that, though, can you tell us a little bit about your background? How did you come to do some of the things that you're doing now? You've got a varied career from research to practice. How did you get here?
Yeah, absolutely. So maybe I could kind of start with my path into clinical informatics, and then I can also talk a little bit about the AI research role that I have. So for me, my journey with clinical informatics really started through a lens of process improvement. After starting my first job out of residency, I collaborated on this project to actually update the order entry workflows in our electronic health record for our primary care department. I had no idea that I was actually working on a quote operational informatics project at the time. I really just was like, oh, I want to kind of make order entry easier and faster. And I think I see some areas for improvement. And that project ended up being so fun and meaningful. And I just found such amazing mentors in clinical informatics. And so that world opened up to me. And then I took on a leadership role as a medical informatics director for primary care and population health in our chief medical information officer's office. Ended up becoming board certified in clinical informatics through the practice pathway. And then as I was working to improve those EHR workflows and kind of the day-to-day help with the day-to-day pain points, I also started to become more interested in artificial intelligence and just recognizing these growing opportunities for AI to help solve problems in healthcare. And that led me to join this AI research team a few years ago called the Heart Team. And they have expertise in AI evaluations with implementation science research methods. And so now I practice clinical care and primary care, do work in operational informatics, and then also the AI evaluation piece.
So, your career path is similar to a lot of folks at this stage, which is kind of it's accidental. You were working on a project and you thought it was one thing, but it turned out to be, once you were finished, you're like, oh, I guess I just did that thing. So a lot of folks don't really understand the importance of operations in not only in every aspect of business, but in healthcare specifically. When you say operational informatics, how do you kind of think about that differently than clinical informatics?
Yeah, absolutely. I'd say they're probably the same. When I think about my hat with operational informatics, or I think clinical informatics is just another way to dub that. And really, it's trying to help with the clinical operations of the day-to-day workflows. And I almost think of sometimes my colleagues as my clinicians as almost like patients when it comes to clinical informatics, because really what we're trying to do is try to help solve the problems that they have with their workflow when it comes to their health IT workflows and the way that they interact with often it is the EHR, and then trying to just help optimize that, make that better. And then of course the end goal is also trying to make care delivery better for our patients. So thinking about just all of the complexities and It's complex, but super fun.
It's not always fun, I suspect, but it's often fun. It reminds me listening to you talk. When I think of operations, I think of workflow. In that you can design the greatest project, but if you don't get the information out to the masses, and if you're not able to kind of communicate the benefits to your target audience, all of that is for naught. Let's talk about implementation science. You had mentioned implementation science. I think probably a good chunk of our audience doesn't know there is such a thing. When I was working for an EHR vendor, we just implemented. We did our best with our customers. But now there's a whole kind of wing of study. What do you know about that? Are you involved? When did you get involved? Tell us everything. Tell us everything.
Sure. So that the research team that I'm on, they're really led by clinicians first. So I think we think of ourselves as like clinician researchers, clinician educators. And so we're trained in primary care, and a lot of us have a background in things like QI, and then of course my background in informatics. I think idea is to really think about implementation as, like you said, bridging those workflows and making sure that when we're implementing any new tool, that it's really we have a good understanding of what is that underlying workflow that we're going to be changing, thinking through workflow redesign, and then trying to evaluate that and make sure that that implementation is hopefully, a success, that it's not creating any unanticipated consequences. And so essentially the kind of overall goal of what we try to do with those types of evaluations. And then our team specifically focuses on AI evaluations. And so, of course, there's lots of implementation science that you can think about with any sort of intervention in healthcare.
All right. Well, you dropped those letters A and I. So let's get to it. I kind of teased an article at the beginning of our conversation in Jamia from maybe 3 or 4 months ago, where you all were among the first groups talking about ambient listening, having an AI write the first draft of a progress note, or at least parts of the progress note. Tell us everything. What is this ambient AI thing? So how did the study come about, and what did you learn?
Yeah, absolutely. I could maybe start with is sharing a bit about how our team came together we have this really cross-disciplinary team that kind of intersects operations, intersects research of IT amongst many other groups. And so really the start of our team was actually back in 2023, after generative AI technology started to become more rapidly available. We were one of the first organizations to pilot a GPT-4 based tool embedded in the EHR that could draft responses to patient messages that clinicians could review and edit. And since we were one of the first to pilot it, it was really an opportunity to study how generative AI could transform real world clinical workflows for the first time. And we were interested in understanding the potential impact of the tool, had lots of questions. Would it actually help with the problem we were trying to solve, which was reducing that in-basket burden on our clinicians? And so through that project quickly came together this amazing collaboration across IT, our CMIO office, heart research team, among several other collaborators. And then that's kind of how my two roles actually intersected. And then after that implementation, we continued to collaborate on other implementations. And so ambient AI being one of those. And then now we're also working on an evaluation of an implementation for another in-basket tool that helps draft result comment notes for patient test results in the EHR. So we are, just now we've kind of formed this new team. And I think the coming together was a key part in that partnership.
So kind of walk us through, if I'm a physician, when you were doing your study, if I'm a physician, what happens? So if the patient walks into the room and is sitting in the exam room, what's the story? How does ambient AI work in the real world?
Yeah. So it's really, if as far as impacting the day-to-day practice, it's actually pretty subtle. And I think that's good. We don't want it to create too many extra steps for our clinicians. So we have our EHR has an app on the phone, and then the ambient listening tool is actually integrated into that. So before I walk into a patient's room, I kind of have their chart pulled up on my phone, and then I walk into the room and usually obviously say hi, kind of check in or introduce myself if I've never met them before. And then I'll actually show them my phone and I'll be like, oh, hey, before we get started today, just wanted to show you this secure recording tool that we're using to help us draft our notes and see if they have any questions. And then literally just press a button, starts to securely record in the background. So all that changes is that I'm typing a lot less. Like I'm not typing the stuff that all the little things that I'm asking about and the patient's history, not typing that anymore. And then at the end of the visit, I just stop the recording. And then usually within a couple minutes, once I'm working on my notes, then there'll be this draft note that gets generated right into my note template. It just populates directly in the electronic health record, which I can then edit and usually requires editing. And then you can go ahead and finish your notes. So that's kind of how it is from that end-to-end workflow standpoint.
So I noted earlier you practice at Stanford, so your patients have heard of technology. Did you get pushback from any patients who are like, no, I'm uncomfortable with this?
You know, it's so interesting. I haven't. For the most part, when I start describing the tool to patients, they just start nodding. They're like, "Oh yeah." In fact, a lot of them will be like, "Oh yeah, I'm using something like that, at work." And I'll emphasize like, "Oh yes, well this is, secure recording tool. Look, it's like part of your chart." And so that has been actually a really nice, nice aspect. And then, of course, hopefully, we need to learn more and try to ask patients and gather those insights from patients when we're not in the room with them, because of course they might have other opinions to share if we're not actually in that room.
I like how you kind of frame it. You've used the word secure in every sense. Hey, this is not being recorded on my phone. It's actually going to a secure space, and awesome. So it's generally well received, and I think that's what we're hearing from people. So what did your study find? Did it work? People like it? Do physicians, do they adapt and adopt it well?
So when we designed our study, we were focusing on metrics linked directly to the problem we were trying to solve, which was trying to reduce documentation burden, trying to help reduce clinician burnout. And so our team actually partnered with Dr. Tate Shanafel, our chief wellness officer, and also a national expert on physician wellness. It was amazing to just have him, right down the hall to be able to help shape our approach to measuring those things like burden and clinician burnout. And our results were encouraging. In just 3 months, this was just a kind of quick 3-month pilot, we had physicians report a 25-point reduction in documentation burden on a 100-point scale, and then a 2-point reduction in burnout on a 10-point scale. And so those were just really encouraging. And then beyond the numbers, we also learned through physician interviews, some personal stories about how the AI was changing their experience through documentation, and just got some really great insights about, what could have driven some of those point reductions or some of the more fun kind of why behind those numbers.
It's fun to kind of talk about the successes. Were there any losses? What were some of the problems? Has anyone kind of pointed out like, oh, I don't like it, I'm not going to use it because of this, or I might not use it for these cases?
What we're seeing is that if among the clinicians that are using it and kind of like using it and start using it, they're actually using it now for a majority of their encounters, like oftentimes 100% of their encounters. And that could be both video visits, clinic visits. But then to your point, there's the who is not using it, right? We want to kind of dig in a little bit more and try and understand those groups. And so a big chunk of who's not using it right now are just clinicians that have never started to use it. So for the group that haven't started it yet, one barrier that we found is that they actually wanted more hands-on support during the initial setup process. And so to help address that, we ended up partnering with our Epic concierge program, which is there's a lot of organizations have these types of programs. They offer personalized one-on-one training for ambulatory clinicians for the EHR. And that program has actually been around for over 5 years. Our clinicians love it. We have this awesome team of informatics educators that provide that one-on-one support. So we ended up embedding Ambient AI scribe support into that existing structure. So clinicians could sign up for ad hoc one-on-one sessions. And then we found that that's actually helped to just overcome some of that initial adoption barrier, help more clinicians successfully adopt the tool. And then we do have a small group of clinicians that have tried using it and then are no longer using it and have decided the tool isn't a good fit for them. And a lot of times that ends up being no editing requirements. So I spoke with a colleague of mine recently in clinic and was just curious because he was in that group, and I was just curious to kind of learn a little bit more. And he said he found the notes were longer than his preferred style. So he felt like he had to edit. And he's like, I'm efficient with my notes to begin with. And so I'm, not for me right now, but he was open to revisiting the tool in the future. And I think that's actually key because we know that these types of technologies are rapidly evolving. And so there's going to be hopefully opportunities to re-socialize the tool if someone didn't feel like it was a good fit for them once there's updated functionalities and, maybe even more deeper workflow integration.
The one pushback I've heard that kind of resonates with me, not so much as a pediatrician, but from an internist standpoint, it was with very complicated patients that some docs have said, writing my note is helps me think. And if I just reading a note that was made by an AI, even if it's a great note, I've lost out on that friction that was built into the whole workflow, and they're worried about that given that lack of the need, if there's maybe a test or an approach that they wouldn't have come to very immediately, but if they have to take 10 minutes to write their note, it will come. Did you get any of that, or have you felt that?
I think that's so important. And we've thought about that actually more recently because we are in the process of doing an early pilot with our first cohort of trainees and trying to kind of think about, how do we think about ambient with trainees and in medical education? And also, what is the potential impact on things like the things that you mentioned, like clinical reasoning, formulation of a differential diagnosis, and assessment and plan, which are all things that are very near and dear to me as an internist. And I'll admit, I'm guilty of, at least in training and in school, having these like really, really long notes, especially with the assessment and plan, just having it be super, super comprehensive. And I think those helped me, kind of really learn about those differentials and go to the evidence and try to put together kind of that comprehensive clinical reasoning formulation. So I do think it's really important that we don't lose sight of the impact on those things. That said, at least now what I've noticed once I started my job, I was like, I don't think anyone's reading these notes but me. So started to rethink, why do I have these really, really long notes? Is it time to kind of rethink my workflow? So this predates Ambient, but I actually started to shift my workflow. And of course, you pre-chart a lot of times before a patient is coming in you sometimes are starting to put together an idea based on why they're coming in and their risk factors. But then I've often started to share my assessment and differential out loud with my patients, during the visit. And so, especially if they're coming in for a new complaint, I'll kind of walk through well, here are the different things that could be causing your chest pain, or here are the different things. And here's what I think is most likely. Here are the things that are less likely, but we've got to talk about them because they're more dangerous. Then I'll type out my instructions and then review them with the patient. And probably a rare person that still prints my instructions out, and no one's taken my printer yet for me. So I'm glad that I could still do that. But then when Ambient, was a thing, I was kind of like, okay, this is nice because in those visits, when I would do that, the ambient would kind of capture all of those things. Whereas before, when I was talking out loud and doing all that, I would then go back and then type my assessment and plan and kind of rehash all of that after the visit. So maybe there's ways to rethink some of the workflows so we could do a little bit more with patients during the visit. But that said, I think that those foundational years were crucial for me to go back, take all the data, really synthesize that material and have the time to do that. And sometimes, even now, if it's a really complicated patient, you have to go back, gather more data. And so, maybe in cases like that, it's going to be changing the workflow to be dictating the assessment and plan. So maybe at the end of the day, then there's less typing, maybe less carpal tunnel, but you're still having to kind of actually dictate the assessment and plan for those types of patients.
Yeah, that seems like a prudent approach, which is it's not 100% of anything. It doesn't necessarily have to be all ambient to the exclusion of you being able to actually write or and when you edit those notes, of course that note's presented to you as a draft and you're able to manipulate it in any way. Are you getting more comfortable, or maybe you're well past this now? So with respect to your physical exam, are you saying aloud what your findings are, or no, that's not what you're doing?
I'm still not. I just, yeah, so for me, the physical exam, as far as ambient goes, I don't think I've kind of leveraged it as much just because I'm not yet in the habit of kind of saying things out loud. Every once in a while, more just to describe it for the patient, I'll say it out loud, but not yet.
Yeah, and I think it's a scribing thing. I remember when I was a medical student, and I remember seeing a dermatologist who absolutely was. He had a scribe, a human back in the day, who came in with him, and he said, he would measure lesions and describe lesions using very scientific language, and the scribe was recording all of that so that he didn't have to do that. And it seems to me like I would still find that quite awkward under a lot of circumstances, but I think people have been doing it for decades. I think it's completely doable under most circumstances, but you got to get comfortable with it.
And I think the tools themselves are evolving a bit. So now I think, like we just recently turned on some customization or personalization features where you can kind of make the drafts a little bit more customized to your preference. You can now take those exams and kind of pre-template those a little bit, which is what we're traditionally used to anyways, our pre-templated exams. But then to your point on the derm stuff, I'm thinking now, most of the time I'm often taking photos and taking photos with my phone with the app and then putting those in the chart. So maybe in the future there's an opportunity for some sort of, multimodal AI tool that could just help summarize, like doesn't even have to in the note give like a differential, but it could at least start by summarizing.
Yeah, I think what we're both coming to the conclusion, maybe it's not so important to describe it if you have a picture of it. In the past, that was really not a common option. Photography was very expensive and difficult to do, and now it's free. So yeah, things things most certainly can change. So you mentioned the ability as the AI evolves so rapidly. Like I don't think we've ever seen things evolve and improve so quickly. I was talking to someone at your EHR vendor a couple months ago and saying, I heard a complaint from a doctor about this thing, and the lead developer said, when? I said, well, I don't know. It was maybe about 6 months ago. And he kind of brushes me off. 6 months ago. Oh my, we can't even talk about something from 6 months ago. Things change so rapidly. He said, I can't really talk to you about things from 3 months ago because it's not relevant today. And that pace of change, even in technology world, time is unbelievable. And so it's it's encouraging that some of the problems that you had. So you had a physician who said, well, the notes are too long and I'd like it to be tighter and I'm pretty efficient. Or I'm sure there's some who are like, well, I like more bulleted problems, or I like kind of storytelling as opposed to just the facts. And people are able to, sounds like, quickly are being able to kind of tell the AI this by programming it. And by programming it, I mean giving it a prompt, right?
Right now, it's more kind of binary options. You can make a note more concise, you can make it longer. I do hope in the future it'll take that personalization even to those next steps. But I think one thing that is promising is the fact that personalization as one of those feed points of feedback has come up in those early pilots, and that now there's already some solutions to kind of help address that feedback. I feel like that's also really exciting because it means that we can gather feedback, share that feedback, and then hopefully actually see that feedback implemented into the solution. So I'm hopeful it's going to continue to get better in the future. Hopefully, it can even learn from our specific style of notes so that we're not having to select from different options. But also, to your point, the bullet points versus having things more in paragraphs, like those are also some of the current options that are available today.
It is moving so quickly. You had mentioned earlier that you're working now on responding to patient messages, and so just to kind of recap for our listeners, it used to be in the olden days you called your doctor's office. You might say, "I'm calling my doctor," but you actually were not. You were mostly just calling your doctor's office, and someone relayed a message to them if they couldn't handle it themselves. And with the advent of patient portals, a lot of physicians started seeing a lot of messages that typically they wouldn't have seen. It would have been handled by someone on their team, but it was easy just to send it to the physician. Thankfully, we're improving that now, and a lot of those messages are being handled by others before they get to the physician. But for the ones that do make it to the physician, you are now able to, under certain circumstances, have a draft response before the doctor even looks at it. How is that working out?
Yeah, so that tool we've had turned on now since 2023, and started in a couple specialties, and then we're actually in the process of expanding that one. I think it it's also had some of the similar outcome metrics, like showing reductions in cognitive burden and also improvements in burnout scores, like we saw with ambient AI. So it seems to be a win. So I think that one we're just in the process of trying to kind of scale and expand that. And then also just looking for other areas of opportunity, other kind of similar problems to solve, recognizing that the M basket is such an area of burden. So that's where we've been doing this recent pilot with this similar type of tool. So very similar to the patient messages, but in this case, it helps to draft a summary of the results for patients for their test results. And so it could be lab or imaging tests. And right now, you, as a clinician, you get those in your in basket in a separate folder, and then you can review those and then put a comment to explain the results to your patients. And so now we're also integrating this option to have these test results that could be draft test results that could be shared with patients.
That's hard.
Yes.
To me, it's much easier to summarize an office visit, but lab results is as a normal result is not necessarily, if it's in the normal range, doesn't necessarily mean a good thing, right? It often does. It almost always does. But there are patients where, like, no, 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 we need that number much lower than the average person because you have this specific disease, and so that takes a lot more clinical insight. And often, I think it's probably not that the LLM or the AI can't do it, but to be successful, it would need to have a large amount of information. And I think what I've heard, one of the restrictions has been in the past that fewer numbers of tokens. So it was difficult to give the AI access to all the information that could help it give it more context. Where are we now with that?
Yeah. So for this tool specifically, it's actually a tool that was built in-house by our IT team. And so that's given us this unique advantage because we can customize the tool from the ground up based on clinician feedback. And so before we did this larger pilot that we're doing now, we actually did some kind of clinician co-development with clinicians and then with the IT team where we had a little over 30 clinicians use the tool, and then we'd have frequent feedback checkpoints. And so it was really fun to see the iterative process because it was developed in house. The changes from the feedback through like a change process control could actually be incorporated pretty quickly, though, compared to, of course, if it's not in house. So to your point, like one nice example of one of the specific points of feedback early on was that the tool was missing important clinical context, like especially if the patient had had that lab test previously or had those imagings, because we know trends are a really important thing that we look at when we're interpreting those test results. And so the team was able to act on that feedback and then kind of update the way that the model works. And so now the draft comments incorporate historical data for those trends. And so it's just one of these nice examples of being able to really get the clinician feedback, but then iterate to try to continue to improve the tool.
Yeah. And that combined with the fact that it's so quickly becoming easier to incorporate more data. That used to be the restriction, right? Well, you can have all of this, but it's going to cost you $1 gazillion. Well, then that's not realistic. We can't do that but as those prices come down and they were predicted to come down, but boy, they are coming down very, very rapidly. And so it's easier to give more data, and with more data comes more context. And it's good to have the lab results for the last 5 years, but also good to see what the physicians wrote in their notes about those lab results, right? And then you do get to that sweet spot where you're able to actually predict what I would say, right? That's when you're most of the time predicting what I'm going to say. I trust you. I used to joke I had a medical assistant who had been in pediatrics a lot longer than I had, and this is all on the paper world. But just to kind of give a sense of, I would sometimes walk in a room, and again there would be a paper chart in the door, and there would be a patient handout. There would be a handout explaining croup or chicken pox or whatever it was, strep throat. And I said, well, my medical assistant, mind you, not nurse, medical assistant, my medical assistant has diagnosed your child with croup. I will now check because she is only right, in my experience, about 98% of the time. And so I need to double check and make sure this is not one of those 2% times. And she got to know me, and she was able to predict what I would say. And she was also able to differentiate what I was going to say versus what my partner was going to say. Because we often, every physician approaches things with a slightly different spin. And when we can start to get technological tools that do that, boy, it's a game on.
No, you're absolutely right. And I think based on feedback, another way that they updated the tool was actually to not try and give like information about next steps or recommendations, to keep it objective, because we know that the next steps can, of course, vary by the clinical context. And so I think with both this tool, with the results, and with Ambient AI, it's still going to come back to trying to make sure that clinicians can still focus on those things that require the highest skill, like clinical reasoning. You see an abnormal test result, and now you go through the algorithm for what to do for that, but maybe help streamline the more administrative. Like if it's especially for normal test results, make sure that patients are getting some nice patient friendly verbiage that objectively explains the results, but absolutely thinking through ways that this is not going to, it's not going to manage results for us, but maybe just assist.
Yeah, and add the color commentary, the flowery language that so many patients like, that so few physicians have time to address. And there have been some studies that the people like the messages that they get from an AI or the responses more than a human. And I think that that's not that the humans, the AKA doctors, are incapable of doing it, just that we don't have enough time. And so it becomes less important. So it becomes more of a, here's the facts, as opposed to, hey, we're going to add some flowery language and really want to tell you that you're quitting smoking is why these lab results are looking better now. And um, it's important to do if you had unlimited time like an AI does. And while we're almost done, let me ask you a penultimate question here. You work in Silicon Valley. I'm sure encounter some of these vendors that you're using now and others who have ideas about AI and healthcare. Any advice to that person in their garage just down the street from you about how to make sure that they understand workflow, that they understand, you know, being human centered and usability? Any high level advice to those folks?
Yeah, absolutely. I think it's just comes down to that trying to think about co-development as much as possible and really think about who's going to be using the tools, who are the key stakeholders. So clinicians, patients, engaging them in making sure that they have some sort of way to help shape the tool and the design of the tool. Really having a deep understanding of the workflows, like you mentioned at the beginning, because otherwise you can't workflow redesign without really understanding the pain points and what are those current state workflows. And then probably, of course, thinking about what's going to help drive someone to want to take that on. Like that gets to some of those outcome metrics or what's the problems they're trying to solve? What's the ROI kind of benefit going to be? And that's working with some of the key stakeholders and, you know, healthcare system leaders for things like that. But I was actually a critic of course, this past week, and was thinking of an example where I was like, this could be done much better. Like I was seeing a patient for what I thought could be possibly a recent TIA. And I kind of had a sense of that before they came in. So it's been a while since I've done a TIA workup. So I wanted to just, make sure I am up to date on the stuff. So I actually pulled up to date, which is kind of it's the clinical knowledge system that I use, going through the articles on TIA workup. And then when I'm seeing the patient, I'm like, talking to them, examining them, confirming that, okay, we should probably go do this TIA workup, putting in each order separately. During that visit, I even pulled up to date again, just because I was like, oh, wait, there's this one. Let me make sure I'm ordering, this imaging study correctly with the right protocol. And I was just like, there's got to, like, this, I'm sure is something that we can do better because there are these really great corpuses of evidence base out there. Ambient has that potential to integrate into our workflows. Ambient knows that I'm talking to this patient and mentioning that, I'm worried maybe this was a TIA. Could it pull up some of those algorithms for me in the chart so I'm not clicking into different screens? Could it then just tee up the orders for me, associate diagnosis codes as I'm talking to the patient? Could it just, when going through the instructions and being like, all right, you're going to call this, number to schedule this, could it just draft those instructions? Because right now I'm still typing them. So I feel like just even shadowing a clinician and kind of seeing and the Gemba could absolutely go really far in trying to help solve real problems.
There's a vendor that is working, I think, on pulling in guidelines
Yep.
based on the conversations that you have. That's where it stops. I don't think there's anyone that's queuing up orders or queuing up patient advice. That's
Yet. Hopefully it's
oh
coming.
no, oh yes, I mean very clearly, yeah, yeah. Well, that is good advice, and one that is well taken. Really understanding what the problem is you're solving. from everyone, all the different perspectives is essential. Otherwise, you might be solving a problem that doesn't really exist. And you don't typically do well as a company when you're solving a problem that no one really has or it's not important. It's time for our last question. We always like to ask the same question to all the folks that we talk to. What is something in your life that's so well designed, it brings you joy whenever you use it or interact with it?
I was thinking about this recently and was actually trying to really think about, like when am I actually excited about it or what's actually kind of making me smile? So I ended up thinking about this app that my son's daycare uses. He's 2.5, and it's this app called Bright Wheel. And so the app is really easy to use from the parents' end. Like it's, no training required. You kind of have everything that you need in there. The teachers use it to update things like nap times and what they ate that day. And they can also send messages to us if they need to update us on something. But my favorite part about it, and what actually makes me smile, is you just will randomly see a photo come in or a video come in of them at daycare. And it's just like, it actually is a time of the day where sometimes during lunch, I'll be like, oh, are there any photos or videos? And, just be able to pull those up and see them. And of course, we take so many photos and videos of our son that I'm always dealing with like storage capacity issues on my phone. But I feel like there's something about, I didn't take these and I'm not there. And I feel like it just helps me maybe connect with him in a way during like a busy week when, we're at work. And just, that's I think something that brings me joy, and it's simple and really easy.
That's great. I wonder what you should be able to do is take a picture of you at work and send that. Well, Dr. Shreya Shah, it was amazing talking to you. And we look forward to you solving all of the world's problems, or at least some of the AI and physician burden problems.
Thank you so much, Craig. It was so fun talking to you, and I learned a lot as well. So thanks for having me on.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Shah, follow her on LinkedIn at linkedin.com/Shreya-Shah. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.